would like to present to you Dr. Glenna Brewster, Vice President of Outreach and Communication Engagements for the SVG Association of Georgia. Dr. Brewster is the Assistant Professor on the tenure track at Neil Hodgson Woodruff School of Nursing at Emory University. She graduated with a bachelor's and a master's of science in nursing, a master's of art in gerontology, and a PhD in nursing science at the University of South Florida. Dr. Brewster is currently funded by the Alzheimer's Association and National Institute on Aging. She is also the president of the board of directors for the National Hartford Center of Gerontology Nursing Excellence. She is passionate about the health of older adults, persons living with cognitive impairment and dementia, and their care partners. So let us welcome Dr. Brewster.
Thank you very much. Is everybody seeing my screen?
Yes.
All right, perfect. So welcome, and let's talk about diabetes. So before I get into my talk, I just wanted to acknowledge the other presenters, and we will describe them before they actually give their presentation. So we have Dr. Roel Brown, Mr. Keon Constance, Ms. Camille John, and Dr. Janella Adolphus. And they'll each be talking about something different that has to do with the management of diabetes. So I am starting us off with the introduction. I'll be talking about the pathophysiology and of diabetes. So I'm going to define it. Then I'm going to discuss the anatomy and physiology of the pancreas as it pertains to diabetes. And then I'm going to provide and finish up with an overview of the most prevalent types of diabetes. So what is diabetes? It is a disturbance in how the body breaks down and put together carbohydrates, fats, and protein. And that usually results in high blood glucose levels. And when I say glucose in the Caribbean, we often say sugar. And due to the impairment from insulin secretion, insulin action, or both. So here we see the pancreas. And the pancreas is actually located in the upper part of the abdomen, right below the liver on our right-hand side. And within it, the specific cells I'm talking about, we have cells called beta cells. And the beta cells actually produce hormones, produce insulin. And then we have the alpha cells, and they produce a hormone called glucagon. And when these hormones are released from these cells, the glucagon, when it's released, it actually increases your blood glucose or your blood sugar levels when it falls below normal. And insulin is released when your blood glucose level is low, and it lowers the blood glucose level. So when your blood glucose level, your blood sugar level is high, then insulin is released, and that would lower it. All right, so how is it exactly regulated? What happens is, so we see in this picture here, let's start from the action of glucagon. So we know we've all done this, we've missed a meal. And when you miss a meal, what happens is that your glucose level drops below what is normal and regular for the body. And when that happens, that this pancreas then releases glucagon. And then glucagon then causes the glucose will enter your bloodstream, and it will go to your liver, and it will say to your liver, okay, we have glycogen. And glycogen is actually many glucose particles. So it's a complex form of glucose. So when we have a lot of glucose in our body, then it's stored in our liver as glycogen. So when we don't have enough glucose, then glucagon goes to our liver, and it says, well, we don't have enough glucose, and what should I do? I'm going to break glycogen down, and I'm going to make glucose so that you would have enough sugar in your body to sustain your cells. It also goes and it triggers the production of glucose from fats and proteins. So it works in three ways, where it works with glycogen, which is sugar, but it also works with fat, and it works with proteins. And then now we have enough glucose in our blood system, so then it's no longer released. It prevents it from being released. Then we have a meal, we have dinner, and after dinner, the body is breaking down everything that we've eaten. And for example, we had a high carbohydrate meal, and in that carbohydrate meal, now we have glucose. So the body has broken it down and it's in our blood system. So then it says to the pancreas, well, we need to get rid of all this glucose from in our bloodstream, and insulin is released. And when insulin is released, then it takes it from the blood and it's taking it now to different tissues. So it's taking it to our liver, and in our liver it's going to convert it into glycogen. It's taking it into our adipose or fat tissue, and it's going to then convert it into fatty acids. And it takes it also into our muscles, and in our muscles it also converts it to glycogen. So then when we start exercising, or when we may not once more have eaten and we need that increase in glucose, then the cycle will then continue. The last thing, however, that tends to be broken down whenever we haven't eaten. So the first thing we heard is it goes to the liver, and then when it's used all of the glycogen in the liver, then it will go to the muscle, and then it will go to the adipose tissue. So while it's easily stored in our adipose tissue as fat, that's usually the last thing where the body goes to get glucose and energy for our bodies. So we have multiple types of diabetes. So the first one is type 1. So oftentimes, well, that is the one that we have so about 5 to 10% of people who have diabetes have type 1 diabetes. And that is where we don't have enough insulin that is produced by the beta cells. And it can be destroyed. A lot of times it can be due to genetics, or if you've had an injury, and because of that injury, then your pancreas is damaged. And if your pancreas is damaged, then it might have damaged the cells that produces the insulin. So therefore you have a deficiency. And a deficiency means that you don't have any or enough of the insulin being produced. And the symptoms of diabetes often develop very quickly, and it's usually developed in earlier years, so children and teenager and young adults. And what we see with the symptoms of type 1 diabetes would be, so if you think about it, insulin often takes the glucose from in our bloodstream and it takes it into the cells, but now we don't have the insulin, so it's not taking anything anything into the cells. So your cells are basically starved. So if your cells are starved, then you're going to be hungry. So we see symptoms of what we call polyphagia, or you're going to be thirsty because you have a lot of sugar or glucose in your blood, but it's like you have a lot. Think about how concentrated it is. And if you have something that's concentrated, in order for you to feel like it's not as concentrated, you have to add water to it. So you're going to be really thirsty because you're going to want to add water to all the glucose that's in your blood system. Then you add water, so you have all that water, so you're going to be using the restroom a lot, so you're going to have that increased urination. And then we see weight loss, also weakness and fatigue as a result of that. So this really develops very quickly, and it's younger ages that we see it. So whenever you see or observe that, you tend to think about type 1 diabetes first. Then with type 2 diabetes, there is enough insulin that's being secreted, but what happens is that the action of the insulin that's being circulated is not working as it should, or there is insufficient insulin secretion to make up for the high glucose. So you have enough insulin, or the normal amount that you have been secreted, but your cells aren't using it efficiently, or it's not taking the glucose efficiently into the cells. And although your cells aren't necessarily getting enough, your body is compensating, or your body is using it well enough that you're not even noticing that this is happening. So your body isn't using the insulin well, and it can't necessarily keep the blood sugars at normal levels. So your blood sugars tend to run a tad bit high. And most people with diabetes have type 2 diabetes. And with this, there's usually no symptoms that you have earlier on. So you can live with type 2 diabetes for years, which is why it's important to get your blood sugar tested if you're at risk. And this one is usually diagnosed in adults. So what are some of the risk factors? Family history. If you have a relative who've had type 2 diabetes, if you've been previously told, so for example, you went in and you were told that you have insulin resistance, so that might be pre-diabetes, your levels aren't in the insulin, in the diabetes range, but they're not in the normal range either, so that in between. So if you've been told that you have that, that is a risk factor. If you're over 45 years old, if you've had gestational diabetes, and I'll go into that a little bit after, or you have a baby that weighed more than 9 pounds, hypertension, high cholesterol, obesity. Those are things that tend to be prevalent in America. We see the African American population, but we see it a lot also in the Caribbean population, a high incidence of hypertension, which is high blood pressure or high cholesterol, or obesity. And even some medications actually can increase your risk for type 2 diabetes. So if you're taking some types of steroid medication, some types of oral contraceptives, some HIV medication, some antipsychotics, so like olanzapine or clozapine, or some antihypertensives. So when you think about, we call them beta blockers. So anything that ends with olol, so metoprolol, or the calcium channel blockers. I know a lot of people tend to take amlodipine. So anything that ends with PINE would be something that you'll think about, that perhaps if I'm taking this medication, I need to be aware and conscious that it potentially may increase my risk for type 2 diabetes. And some thiazide diuretics, so hydrochlorothiazide would be one of the medications that can potentially increase your risk for type 2 diabetes. And then gestational diabetes. So this is the diabetes that develops in pregnant women who've never had diabetes before. So you've never had a risk, or you've never had diabetes, then you get pregnant. And during pregnancy, you're tested multiple times, your blood sugar is tested. So whenever you're tested, it could be then that you've tested in the range to be diagnosed with diabetes. So that's gestational diabetes. If you have gestational diabetes, then both you and your baby could be at risk. And some of the risk factors would include like excessive birth weight, so like a larger baby, a baby on the larger side, putting you at risk for potentially having a cesarean section, preterm birth, low blood sugar, for the baby, obesity and type 2 diabetes later on in life for the baby, or even stillbirth. And for the mom, potentially high blood pressure or preeclampsia. So preeclampsia tends to be high blood pressure during a pregnancy, and in a particular range. So they look at that and monitor you as you go through your pregnancy, having a C-section or even future diabetes. So having gestational diabetes actually increases your risk for type 2 diabetes later on. And then, so some of the risk factors for these, being overweight or obese, not being physically active, prediabetes, if you've had it during a previous pregnancy, previously having a baby over 9 pounds, or being of a certain race or ethnicity. Once more, being Black shows up in this. And then prediabetes, that is blood sugar levels that are higher than normal, but not as high for you to have a type 2 diabetes diagnosis. And prediabetes actually increases your risk for type 2 diabetes, heart disease, and stroke, which is why once more we emphasize the importance of getting your annual check. So, if you go to your doctor and hypothetically they may not remember to do it, to ask them whether or not they can order and have you do your annual blood test to check what your blood glucose levels are. So, does anybody have any questions? We maybe have like 3 minutes or so for questions, and then we'll go on to the next speaker.